Okay, and it looks like we are ready to begin the webinar. Hi everyone, I'm Seth Petrie, Marketing Manager for CQL, the Council on Quality and Leadership. Thank you for joining us today for the webinar, Personal Outcome Measures in Recovery. This is part of our webinar series on advancing recovery and behavioral health, and they are all presented by Cherene Allen-Caraco, the CEO of Promise Resource Network. We are recording this webinar, and we'll make the recording and PowerPoint slides available on our website, which is www.c-q-l.org. We will be taking questions, which you can type into the question box on your screen. Then I'll share those questions with Cherene to address at the end of the webinar. So now I will hand things over to Cherene.
Hello, everybody. Welcome to the last of our web-based series. We have, I think this is the fifth out of 5. So thank you for joining us for this one. This is talking about how we utilize at CQL the outcome measures and basic assurances to promote recovery. And what I'm going to do is share with you some of the things that as staff at CQL we look for when we go to behavioral health agencies and we're reviewing the personal outcome measures and the basic assurances, the specific type of information that we are looking for that are indicators that the agency is utilizing these tools in a way that really promotes recovery. So I'm going to share with you some tools that we had created that are sort of enhancements or amendments to some of the tools that you may have already seen today. So I'm going to start, and we're going to just quickly go through the personal outcome measure piece of it, because I really want the focus to be on the basic assurances and sharing with you what that tool ends up looking like. For those of you who don't know me, my name is Cherene Allen-Caraco. I have been working for CQL for, gosh, it's been around 5 years now. I work primarily on the side of behavioral health, as well as with states that are supporting people with co-occurring developmental, intellectual, and other disabilities and mental health or substance use issues. And so you probably don't see me in a lot of accreditations, and part of it is because I do more specialized projects for CQL. I am also the CEO of a behavioral health agency out of Charlotte, North Carolina. We are a peer-run agency, which basically means that everybody, including myself, is in recovery from mental health, substance use, or both. We have a team of employees that have experienced homelessness, incarceration, and similar backgrounds to the folks that we are serving. And we utilize our personal experience to help people move forward in their own lives and get away from that cycle of dependency, poverty, and illness. So that's just a little bit about myself. Okay, so we're going to start with the personal outcome measures, something that should be really familiar with you. I'm going to talk a little bit about it in the context of recovery, so I want to make sure that we have a shared understanding of what I'm referring to when I talk about recovery. This is one of my favorite definitions. If you've been on webinars, you've seen this before. But I think it really captures the essence for those of us who live with mental health and substance use issues of what this means. It's no longer viewing oneself primarily as a mental patient, and I would add to that client, consumer, whatever word that's used to insert a person who receives services, but no longer viewing oneself primarily as that and reclaiming a positive sense of self. So recovery happens when we start to view ourselves in a bigger world picture and see ourselves as a potential homeowner, an employee, and spouse, not just a client of services. When you become a client of services, it really limits your identity, your self-esteem, and the opportunities that you see yourself having in life. Recovery is about having a quality of life, whatever that is to the person. For those of you who utilize personal outcome measures, you already know that we can't give one definition of quality of life, and therefore we can't give one measurement tool that gives you that clear definition. That in personal outcome measures, the first step is to understand in all those areas of somebody's life what they're looking for, what is meaningful to them, and how they define quality. And so it's having a high quality of life based on their definition, which means moving beyond the illness, moving beyond this idea of just stabilization and maintenance, and having a life in the future that you actually want to live. that moving beyond stabilization and maintenance is really a key point for providers and service organizations to understand. Our service delivery system on the mental health and substance use side has really been designed around this idea of the goal is to get people to be stable and to be able to function and then to be able to maintain that. What we have learned from research and we've learned from people in recovery themselves is that people don't want to be stable and to simply function. People want to thrive. That is, I want to figure out how to live my life with this thing called mental health issues or substance use issues or whatever the diagnosis is. I don't want to have a life that is the central part of it is my symptoms and my treatment. I want to be able to have a life and fit the symptom and the treatment around it, but in ways that don't impact the life part. And so what we do is challenge organizations to think beyond stabilization, functioning, and maintenance, and thinking about it in terms of thriving. If you're working with people and their life is a service-based life, which means that they go from their group home or supported housing to their day program, to their group counseling, to their individual therapy, to their medication management. Maybe they volunteer once in a while. Maybe they go to a psychosocial rehab program. But their life is really surrounded by services, then we know that that person is not living their best life, that they're not living a life outside of that of being a client. And so that's what we're really looking for at CQL when we're going in and we're looking at the supports that people are being provided with. We are at a point in our behavioral health community, which is actually a beautiful thing in many ways, where we are understanding how people recover. And the sort of key ingredients, while we can't have a formula, we do know that there's certain things that really enhance recovery. But we are starting to learn it through research. Historically, in our behavioral health community, a lot of what we have done has been based on philosophy. It's been trial and error. And that has resulted in a lot of what I refer to as legacy programs. Legacy programs are, well, we do this because we've always done it type of programs. We want to move beyond that and not just do what we've always done, but realign and do what actually impacts people's lives in positive ways. And now we have all this information out there to provide us with the tools and the guidance to be able to do that. So one of our leading experts, if you will, in mental health and substance use recovery is SAMHSA, the Substance Abuse and Mental Health Services Administration. And what they have done is created definitions of recovery and wellness based on the research that they have gathered. And so they have really reduced it down to 4 different dimensions of recovery, and they are health, home, purpose, and community. And really briefly, what that means is health is about physical health and emotional health. Home is about being in a home that is not temporary, is not based on just a subsidy, that is not one that I'm placed in, a home that feels safe and it's mine. Purpose is about having a reason to get up every morning and live your life. So that really is typically around employment and education. And community is that connection with people that love you, that you love, and having a real identity in your community. They also looked at the idea of wellness and what supports emotional wellness, and they came up with 8 different dimensions of wellness. Number 1 is emotional wellness. Number 2 is environmental. What that means is being in physical environments that really promote healing and promote health and promote wellness. So those sterile environments of the past, the cinder blocks, blue walls, gray walls, that really does not do a lot to stimulate health and healing. So environmental wellness is really a key to people being healthy. Financial, having that level of independence and freedom that we all enjoy. Intellectual, having intellectual stimulation. And I've said this on one of my webinars before, when you're put into the role of a client, your job is really to comply, which means that your job is to do what other people say that you need to do and not ask a lot of questions and just do it. What happens to our brain when we get into that role is we get into this dependency cycle where we don't have to use the portions of our brain that assimilates information and is used to make decisions. And so that portion of our brain can really atrophy. And then you don't have a lot of intellectual stimulation. So just like your body, if you don't use it, you're going to lose it. Your brain is the same way. So one of the things that we're learning is if the person keeps going to the same day program, sitting in the same groups, sitting in the same seat, and they have no intellectual stimulation, their illness actually gets worse and worse. And so a key component of wellness is having that ability to strengthen the brain and strengthen that muscle. Occupational wellness is about your vocation and doing what you love to do and having opportunities to earn a living, earn a paycheck, and contribute in meaningful ways. Physical wellness is obvious. That's about our physical body and our health. Social is about the connections we have with others, and spiritual may include religion, but it really is about having a bigger purpose or bigger sense of the world and what that means to me, and being able to be free to practice my spirituality. You're going to see that embedded in the personal outcome measures and the basic assurances are all 4 and all 8 of the dimensions, and we're going to talk a little bit about them and how they apply in both the POMs and the basic assurances. So here are some tips and tools. In the personal outcome measures, and one of the things that really sold me about POMs when I came to CQL is that oftentimes within the behavioral health community, we are taught to look at clinical outcomes. And clinical outcomes really are about symptom reduction. So reducing anxiety, increasing, not even hope, I was going to say hope, but that's a completely different thing. So it's really about that symptom reduction, managing the voices, decreasing depression. It usually looks at those very clinical outcomes. Some organizations also look at functional outcomes, and the functional outcomes are really more around, can I tie my shoes, can I make my bed, can I wash dishes? And so it's another set of outcomes that are sometimes used within organizations. The limit that I find to those 2 sets of outcomes is they say very little about what the person actually wants in their lives. Most people I know, reduction of my symptoms is not what I'm looking for. I'm actually looking to live my life despite those symptoms and learn how to live with them and manage them as they come up. And that's a very different thing than reduction of symptoms. Functional outcomes, how important is it to me to make my bed and to learn how to tie my shoes? Well, it depends on the person. I can tell you, for me personally, I could care less about either of those things. So if you make that my outcome, I promise you I will be both non-compliant and I will disappoint you, and your outcomes will look terrible because I will not work toward either of those things. So personal outcome measures really is about health, wellness, quality of life, and ultimately recovery. And sometimes that has to do with clinical, sometimes it has to do with functional, but all the time it has to do with the person. And the areas of their life that they find meaningful, that they say, if this was better, if I could have an impact on this, my life would have more purpose, more meaning. I would feel like my life was a better quality. That's really where the personal outcome measures come in. What's so different about them? Well, they're really universal. They're outcomes that are important to all people. If you do personal outcome measures, you know that the domains that are identified are no different for you and your family members than they would be for the people that are coming to services. It's all about health, living a life, having connections with people, feeling safe, all those things that we find that are important to us. They're inclusive of both recovery and clinical outcomes, but they're not limited just to them. They're defined by the person. Now, this is a big thing in behavioral health because typically outcomes are defined by clinical assessments. They're defined by those diagnostic labels. They're defined by the treatment providers. They're defined by regulations, but they're not typically defined by the person. We have so many standardized, reliable, and valid outcome measures, and there's a lot of great information in there, but that doesn't necessarily mean that it's what's important to the person. And so POMs are not defined by those outside things. They're really defined by the person. And as you know, they're broken down into 3 different areas: myself, my world, my dreams, and then where they overlap. So I'm not going to go through all the details, but I am going to show you in those domains that we talked about where they fall in on the personal outcome measures. So if we look at the myself area, myself obviously is the personal, physical, environmental aspects of our lives. On the recovery side, if we look at the domains and the dimensions, it really is synonymous with the dimensions of health and community, all embedded in those personal outcome measures. Natural support networks, intimacy, safety, health, rights, being treated fairly, abuse and neglect, and being free from those things, continuity and security, and personal information is what the myself is all about. Under my world, that's the connection that we have around people and places and opportunities to live a life. And if you look at the dimensions of recovery, those are embedded in home, purpose, and community. And so this is where I live and where I work, and using my environment, being connected and integrated with the community and the environments that I go to, and having social roles and choosing services. And then the last one, my dreams, it's all about the exploration of self and choice and self-determination and how I want my life and my world to be. This really is embedded in the personal definitions of recovery. And so one of the things that I say to the provider community is if we don't understand how the person defines recovery, and they don't have to use that word, that's the word that's universally used right now, but if we don't understand how they define their best life, their best quality of life, their recovery, whatever that is to them, how in the world do we know if we're supporting them to go in that direction? And so my dreams is all about helping people imagine and dream again, understanding how they envision their life to be, and then making sure that we are providing meaningful supports for them to go in the direction of their dreams. And that obviously comes in the direction of goals and having friends and being respected. And then, of course, my focus is what's important to me now. We typically find in our personal outcome measures that there are around 3, maybe 2 to 4, but usually 3 areas that are the most important to me right now in my life. That if these things were to change, if I were to make movement in these 2, 3, 4 areas, my life would improve in so many other ways. That's really what my focus is now. One of the things that I really like about my focus is you can use that information to create a person-directed plan with somebody. Those are your areas, your 2 to 3 goals of things that we are going to work on now. It doesn't mean that all the other areas are not worked on. It just means that they're not my priority at this point in my life. And so it gives us really great information to do some strong person-directed planning with people and walk away with a person-centered plan or a treatment plan, whichever you use at your organization, that really does reflect the person. So we know that when we are making decisions about personal outcome measures, we are wanting to measure 2 things. Number 1, the quality of life. Is the person, have they defined their quality of life, and are they there yet? And number 2, are we providing the support to get them closer to their quality of life? And that results in our personal outcome results worksheet. Now, when I'm doing the personal outcome measures, I'm specifically asking for questions around health, home, wellness, recovery, all of those things that I just shared with you, and maybe introducing a new language to people and seeing how well we are actually exploring those things with people. Okay, so I just wanted to do that as a quick overview of personal outcome measures, because what I really want to be able to focus on is the basic assurances, partly because you have probably not seen this before at your organization. So let me tell you a little bit about this and how it was developed. CQL has what we call the BA Companion Guide for recovery-oriented agencies. And I actually am the one that created the companion guide. What I did was take that thick basic assurances manual and I translated it through the lens of recovery. So as you all know, the basic assurances are all around health, safety, and human security. And while those things are completely universal, there are some nuances that occur within behavioral health, so that if somebody is not versed in that system, they could easily be overlooked under the basic assurances. And so I took all those basic assurances and I translated them through recovery, evidence-based practices, and recovery-oriented organizations, and I created a companion guide that is used by the CQL employees when we go out there to do accreditation, to look at basic assurances through the lens of recovery. What I'm going to share with you is language that comes exactly from the BA manual, just so that there are no guesses. We're not trying to trip anybody up or put something in there that you're not expecting or doesn't make sense to you. So you're going to see the factors. There are 10 factors in here for basic assurances. You're going to see the way that it's written in the BA manual. And what I'm going to do is share with you some examples, illustration, resources, and information around that particular factor. So factor one is all about rights protection and promotion. And when we talk about folks with mental health and substance use issues, we see way too frequently, actually, there are restrictions on personal rights that are based on clinical decision making. And sometimes they're done, frequently they're done, actually without due process or any legal justification. So here's an example. It's to go into a program. I just reviewed a program description last week, as a matter of fact. And there are 2 rules in that program description. Number 1, you can't have illegal substances on premises. Makes sense. That is a law. That completely makes sense. Number 2, you can't engage in sexual relationships in the while you're living in the program. That's one that caused me to pause and say, okay, what are the parameters around an agency being able to restrict somebody's rights for intimacy in that way in the name of a program rule? Is that a rights restriction that is legal, or is that a violation of human and civil rights? And those are examples of things that happen commonplace within the behavioral health system. And what we do oftentimes is use them to get people to follow the rules. And if they don't follow the rules, then they can't stay there, so they're kicked out of the program. We really need to examine that and how we're doing that in the guise of treatment or under the guise of help for people. So here are some examples, and this one we see frequently. Limiting the right of a person to review their chart or file because a clinical decision has been made that it would pose a threat, create stress, or negatively impact the therapeutic relationship with the organization. I have gotten into many debates with social workers and clinicians about the idea of somebody being able to view their file and their notes and everything that goes along, their assessments, things like that. What I frequently hear on the clinical side is it would set up a negative relationship, or it would trigger somebody's symptoms. And so we have decided as an organization that they do not have access to their chart. I really want to challenge that thinking. Number one, my question is, why would there be anything written in the chart that you're not sharing directly with the person? So if you're saying negative things or things that can be perceived as negative in your chart, are you not having that conversation directly with the person and sharing your concerns or your questions or your observations? Why would it be a surprise for them to pick up a chart and read information about them that is new to them? That's not a good practice. Number two, do we have the right to limit somebody's access to their medical records? In the general public, we do not have the right to do that. And so why is that different within a behavioral health system? It doesn't make sense. And number three, is it actually legal to be able to do that? So these are questions that I ask when I go into organizations. These are the types of restrictions as CQL, when we go in, that we look for. We review any perception of what could be a legal, a human, a client, or a civil rights being violated, and we ask a lot of questions. Some of them are examples like I have below under the bullets. A person's right to choose a different provider, Under the threat of hospitalization or punitive discharge, people might be told that they cannot voluntarily choose different services or different providers. Obviously, that's a rights violation, and that is not something that can be practiced within our service delivery system. The second one is one that is incredibly controversial. I know it's very controversial. I wish that this were not a webinar. It was more of a in-person learning, because there's a lot of conversations that can be had around these things. But a person's right to refuse medications. Many behavioral health agencies actually require the people to take medications as prescribed, or they will be involuntarily committed, or they will be discharged. This, again, is a rights violation that we look for, and I'm going to go into more detail about that in a little while. A person's right to change rep payee or become their own payee. And what we're looking for with this, with CQL, is, are we having the conversation with people? Are we reviewing their payee status with them at least annually, if not more frequently? Are we providing them with information that they have the right to petition to have their own payee, or they have the right to petition to change their payee, or what it would take for them to have control over their own financial situation? I've just come across a couple of situations just in the last 2 weeks where we had rep payees that were skimming off the top, meaning they were taking money from the person, the finances, that they were the rep payee, and they're taking money illegally. And because these things are not reviewed consistently, there's not an outside advocate, or the person themselves may not have enough of an understanding of their own finances, these things often fly under the radar. As a behavioral health agency, we want to be very aware of this, and we want to support people to make good decisions and to understand what's happening around their finances, and be able to choose to change a rep payee or to be able to petition themselves. Termination of parental rights, so children being removed and placed into foster care or the state's custody without due process because the parents may have a mental health or substance use issue. We have seen this numerous times, and when we've gone back within the court system, what we are being told is DSS, Department of Social Services, whatever it's called in your state, has the right to remove children and petition for termination of parental rights. And while that may be the case, there has to be a real due process in place. The person has to understand the due process. They have to be able to secure legal advisement themselves and be able to understand the legal implications of parental termination. And so we want to make sure that that has been done. If it has not been done, that the agency is doing something about that in going back and supporting due process. Kids cannot just be removed, and parents' rights cannot just be terminated based on opinion. Legal restrictions of rights. So courts may intercede and legally remove a person's right to carry weapons due to their criminal history or some other reduction of rights. In these situations, we just want to make sure that the organizations are informing people of the legal process and what they need to do to either restore their rights or make sure that they're not violating their rights restrictions that are in place. And then involuntary commitment, it's called different states and different things in different states. It's basically committing somebody to a psychiatric hospital or a psychiatric unit against their will without their consent. It is one of the most frequent rights violations that we see within the behavioral health community. We want to make sure that organizations are preventing hospitalization absolutely whenever possible, engaging people to make informed decisions about treatment, and discussing the benefits and consequences of hospitalization, as well as using involuntary commitment, if the agency does use that, is the absolute last resort possible. I can tell you in the 10 years that my organization has been in operation, we have not done one involuntary commitment. And part of the reason why is because, number one, it's been unnecessary. We've been able to establish enough of a relationship with people that they have made decisions about what makes sense to them and what doesn't make sense to them around their treatment. But number two, we are a no IVC agency. We do not do involuntary commitments for people. And part of the reason why is because it really diminishes personal power, personal voice. And it can be one of the most, experienced as one of the most outrageous human rights violations and trauma. It can truly trigger somebody's trauma reaction when they're committed against their will. So we, as a rule, do not do involuntary commitments and always look for other options with that. And then the last one is coercion and threats. We also see this a lot, and this comes in the form of, if you don't follow the rules, you're going to be discharged. If you're not compliant with treatment recommendations, you're going to be hospitalized. Some things are very subtle. Some things are very overt. But the coercion and the threats, particularly because we have the power of somebody's home, for example, in our hands, we can kick them out of their housing program. It's really easy to go into that coercion and threat to try to gain compliance for treatment or compliance over behavior. That is a violation. That's a human rights violation and should not be used. Plus, it's very traumatizing, and it creates a lot of safety issues within the organizations. There is this really great article that's called When Help is Not Helpful, and it's written by a very strong international public advocate for human rights for people with mental health and substance use issues named Pat Deegan. And this is a quote from the article: "Help isn't help if it's not helpful. Help that is not helpful can actually do harm. It is simple, and yet it is incredibly powerful." We can do an entire training just on this idea that there are some things that we do professionally because we've been taught to do them, or our system has required it, or our agency has put it as a part of the rule, that we think we're doing it because it's helpful, but it's not experienced as help by the person. And our best intentions, it doesn't matter how helpful we're trying to be, if the person doesn't experience it as help, they don't feel it as helpful. And it actually can be doing the opposite and be incredibly harmful to people. And so that's why we want to stop and think about the things that we're doing, the interventions we're using, the tools that we are using within our organizations, and make sure that we're asking people whether this is actually helpful to them or if it's harmful to them. This is another quote: "We must dare to talk about help because power, including the power to oppress, often disguises itself as help." That is a mouthful. And that is what we're talking about under this particular factor with CQL. When we use power over people rather than handing power back to people, what we are actually doing is oppressing them. And we do it because we've been trained to do it sometimes. We do it because we think it's being helpful. But it could actually be doing the opposite. Power disguised as help is used to silence people with disabilities. 1989, Paulo Freire says that oppressive power submerges the consciousness of the oppressed into a culture of silence. Toxic help oppresses and silences people with disabilities. And we're going to talk a little bit about this idea of toxic help. But what happens is if somebody has been oppressed for years and years and years, or they just have one example of oppression. The agency said, if I don't do this, I'm going to be kicked out of my housing program. What it can do is push people into this culture of silence where they just suck it up and they do what's being told to them out of fear of retaliation. That is abusive. It's another variation of abuse. And that is what we want to be aware of, be conscious of, and be mindful to not do to people that we have power in their lives. We don't want to misuse it. She also talks about this continuum of help, and on one continuum is called neglectful help, and on the other continuum is called toxic help. Let's start with toxic help because it's the easiest to try to understand. Toxic help is when we assert our power and we use words like no. So, or that's not an option, or you can't do that. It's having power over another person is toxic help. So somebody comes to you and they say, I want to go off of my medication, and you say to them, nope, it's not an option. If you try to go off your medication, you will be deemed non-compliant. That's an example of toxic help. Why is it toxic? Because it's, number one, it's really not helpful, and number two, it's really actually harmful. Asserting your power and authority over somebody else is toxic help. The other thing that's toxic help is actually doing for people rather than investing in people to learn how to do for themselves. And that comes under the guise of, well, you know, this person isn't able to make that phone call, and so I'll just make it for them. It's just much easier if I do it myself. That's an example of toxic help. Neglectful help on the other end is when we do the opposite. When we stand by, well, this is an adult. They can make their own decision. They know what they're getting themselves into. They should know better. They need to make that phone call themselves. That's not my job. That's neglectful help. So when we use well, these are adults, and you want to make that mistake, go ahead and make that mistake. Reason why that's neglectful is because there's a reason why the person is in services. If they could just easily make that decision on their own without support, without some help around informed decision making, they wouldn't need you as a service provider. So by neglecting that job, that role that you have, it's not helpful. Neglectful help is by saying, you make your decisions, you suffer the consequences. Toxic help is by saying, I want to prevent you from any consequences, so I'll do it for you, or by using the authority card. We're looking for a middle ground where we are investing in people to make informed decisions, we are supporting the decisions that they're making, and we're helping them come up with safety nets just in case the decision does not go well. So here are some examples, and obviously we can't have a conversation about it, so I'm just throwing them out there for you to think about. Is this helpful or is this harmful? Telling someone that you're working with that if they don't comply with taking their medications, they will be sent to the hospital. Is that helpful or is that harmful? I'll tell you an example from a personal experience. I was given a psychotropic medication that within 3 days I was acutely suicidal, and within 5 days I was experiencing psychosis. I have never experienced psychosis before. I have experienced suicide attempts. That medication that I was being prescribed was toxic to my system. If I had gone to my doctor and my doctor had said, well, you don't have a choice, you need to take your medication, and if you don't, you're going to be sent to the hospital, that could have ended up killing me or putting me in this altered state of reality that it could have been incredibly difficult for me to ever get out of. When somebody wants to go off their medications, we have to have real conversations about why and what it is about it that is not working for them and what those alternatives are. Is it an option to go off medications? Absolutely. People do it every single day. And the truth of the matter is we would rather support somebody to do it safely and have some backup options in place than to just say, nope, you need to stay on your medications, and for you to leave and for them to spit them out and dump them down the sink. That's where we create safety issues. Having an agency rule that states that if a person doesn't follow the rules of the program, they're going to be kicked out. Is that helpful or is that harmful? I have worked in many residential programs that have had rules like you can't drink a soda in the living room. And then I come home to my own house and I drink soda in any room that I want. Sometimes we have to try to understand why these rules are put in place and question, are they put in place to make it easier for the employees? Are they put in place to assert authority? Or is there a real therapeutic reason why these rules are put in place? And we have to be honest about those answers. I've used the example in the IDD system. I've worked in states where there was a interpreted rule that if you have a developmental disability and you're in a service, you cannot eat a hot dog. because of a choking hazard. So I jokingly say somebody in 1858 once choked on a hot dog, so now everybody with a developmental disability is prevented from having a hot dog. We have to question some of these rules, where they have originated from, why they're being put in place, instead of just going to these are the rules, you don't like it, then you lump it, and you're going to be out on the streets. That is not helpful to people. Using cigarettes to control behavior, one of the biggest health risks that we have within our behavioral health system is cigarettes. And part of the reason for that is we have historically used cigarettes as treatment, and people have become addicted. Now we've gone in the opposite direction where we're trying to have a cigarette-free zone. So now people are addicted, and we're trying to remove them from them. So either way, we really need to step back and take a look at this issue around cigarettes. You can use any word in there. You can use food. You can use babs. You can use new clothes. Anything that we are introducing or trying to remove in order to control behavior is harmful to people. So we have to find other ways. And then using level or point systems to reward or consequence based on attitude and behavior, helpful or harmful? Well, I think the answer probably depends. I'm not going to weigh in terms of an opinion on this one, but I will tell you that it's part of what I look for when I go out to agencies, and I try to understand how these systems are being put in place, how they are actually related to anything therapeutic, whether they're being done just as an authority play, or whether they are actually connected to something that is helpful to people. And I want to look at and see whether the level or point system is any violation of human rights, client rights, or civil rights as well. So those are just a couple of examples. Here's a list of things that we're looking for. Exploitation, threats and coercion, forced treatment, overuse of medication and sedation. I will also say underuse of medication and sedation, use of restraints and seclusion, aversive conditioning. So that would be something like, I worked in a group home once with folks with intellectual and developmental disabilities, and the overnight staff had a water bottle that if somebody tried to get out of their bed, they would spray them in the face with the water bottle. That was an example of aversive conditioning. Lack of privacy and humiliation, locking of cupboards, pantries, and refrigerators. Obviously, there has to be a human rights review whenever we lock something up and we keep people, we prevent them from having access. That alone could be a training itself. Lack of decision-making of options that are actually important to the person. So are we limiting their options based on whatever reason? Behavior plans that are aimed at controlling behavior rather than supporting people who are living with difficult life circumstances or struggling with different emotions. Diet and other restrictions, imposed sleep times, withholding of money, food, possessions, preventing of intimate relationships. So those are all examples under number 1 for CQL's basic assurances. How do we combat this? Just a few things on this. Number 1 is these things that are often done are just frequently done unknowingly, right? So they're not mean-spirited or ill-intended. They're just ill-advised. And part of it is because we don't realize that when we are in this field and we are serving people with diagnoses that are coming to us for services, we have an implied power. And the power is, as soon as you have keys, as soon as you have a job description and a title, as soon as you have a badge, you have authority over people. Most people don't realize that they do have that power and that they're unknowingly abusing it or misusing it. And so one of the ways that we combat this is by creating that awareness and that mindfulness of some unintended and subtle ways that we can misuse power if we're not aware of the fact that we even have it. Here's a tool called let me just pull it up. It's called the Power and Control Wheel. This is the same wheel that's actually used around domestic violence. And it's the way that caregivers, service providers, family members can unintentionally misuse power and control over people. And it's everything from coercion and threats, which we talked about. If you look at that section, it's withholding basic support, withholding rights, terminating relationships due to noncompliance, being more intrusive, using consequences and punishment to gain compliance, pressuring the person to engage in fraud or other crimes. Those are examples of coercion. Then we have intimidation, raising a hand using locks, actions, or gestures to create fear, destroying property, misusing pets, service animals, displaying weapons, emotional abuse, punishing, ridiculing, refusing to speak to a person. I think we therapeutically used to call that planned ignoring, ignoring requests, ridiculing the culture, the traditions, the religion, person's taste. All of those things come under emotional abuse. Then there's isolation, and that's about controlling access to fill in the blank, whatever that is. Minimizing, justifying, and blaming, so making light of abuse, denying the person's pain, justifying rules that limit autonomy, dignity, and relationships for the sake of the program's operational efficiency. Excusing abuse as behavior management, or blaming the person with a disability. Withholding, misusing, or delaying needed supports. So that's overuse of medication to sedate people, ignoring equipment safety or requirements, not fixing adaptive equipment, or making sure that adaptive equipment is plugged in and ready to be used, destroying communication devices, withdrawing care. All of those things are under there. Economic abuse is misusing somebody's property or finances for personal gain. It's stealing and making financial decisions for the person without their involvement. And then the last one is called caretaker privilege, and that is treating a person as a child, as a servant, making unilateral decisions regardless of the person and their individual needs, limiting their roles and responsibilities, providing care in a way that increases dependence and vulnerability, giving your opinion as if it's the person's opinion, denying the right to privacy, ignoring, discouraging, or prohibiting the exercise of full capabilities. So there are some ways that this could easily happen within a power play relationship or a power relationship in which we are providing services to a person. Oops, sorry about that. I went from the beginning. Let me go back. And you're going to have that as a handout. One thing that you can do with it is actually use it as a training tool in your agency. Okay, so number one, we are aware that there's a power differential, and we utilize this information and share it with people. Number two is really understanding your role. How do you view your role? How does the agency view your role, your colleagues, and the person supported? Which ones apply to you? Are you considered a behavior monitor or somebody who's monitoring treatment compliance? Are you an educator? Are you providing people with information? Are you a healer? Is your role to foster the healing of people who've experienced emotional distress and trauma? Are you a mentor? Do you provide support and guidance and live by example? Are you a manager? Are you managing the person, managing their behavior? Are you a partner? Are we here together equally trying to figure this out? Are you a supporter? Is my role to offer you support as you make your decisions? Or are you a caretaker? My job is to take care of you. What is the difference between monitoring someone's compliant with treatment versus partnering them to make decisions about the type of treatment they're interested in? What's the difference between a caretaker and a healer, for example? A caretaker, right off the bat, says, you're incapable, and my job is to make sure that all your needs are taken care of. A healer has a very different role, a very different responsibility, and a very different way that they operate. An educator says, my job is to provide you with the information, and then I'm going to support you to make those decisions. A manager says, It's not about the information. It's about making sure that your behavior is managed. And so depending on how your role is viewed by yourself and those around you may mean the difference in how you're actually utilizing that role. The language is different for each of the roles. The tools and the approaches are used in each of these roles. So it's something to think about as you're considering how to shape your organization, or if you're already doing it, how do you continue doing the great work in supporting people effectively? Asking what is helpful and not helpful, and this is literally asking the person, what would help you right now? What would you find the most useful? What is one thing that I can do that will feel supportive to you right now? Asking what is not helpful. And the most important part of that is actually listening, and not listening in judgment or not listening in a defensive posture, but actually hearing what the person is saying and being willing to adjust. Having empathy is a huge piece of it. It's really easy sometimes to go in and be overwhelmed with our job because we have so many requirements without understanding what the person in front of us is actually experienced in their life or what they are experiencing. So keeping in mind that as difficult as it may be for you, you get to go home. This person is there in their situation and in their life. And are we making it better? Are we keeping it static? Or are we making it worse? And how do we show up every day with that sensitivity and empathy? This is a really great poem called The Other Side of the Desk. I'm going to read it out loud, but you have it here as well. Have you ever thought just a wee little bit of how it would seem to be a misfit and how you would feel if you had to sit on the other side of the desk? Have you ever looked at the man who seemed a bum as he sat before you nervous, dumb, and thought of the courage that it took him to come to the other side of the desk? Have you thought to yourself of his dreams that went astray, of the hard, real facts of his everyday, of the things in his life that make him stay on the other side of the desk? Have you thought to yourself it could be I if the good things in life had passed me by, and maybe I'd bluster, and yeah, maybe I'd lie from the other side of the desk? Did you make him feel he was full of greed, make him ashamed of his race or his creed, or did you reach out to him in his time of need, to the other side of the desk? May God give us wisdom and lots of it, and much compassion and plenty of grit, so that we may be kinder to those who sit on the other side of the desk. So how do we combat violations of rights? Well, one way is through empathy. And if we have an empathy and an understanding, or at least try to understand where the other person is coming from, it may go a long way. The second factor in this, and I'm just going to look at time, is dignity and respect. This actually comes from our Basic Assurances companion guide. We're looking for dignity of risk. It's a key ingredient in recovery, and organizations honor and respect each person's freedom to take risks, even when the risk may be contrary to the treatment recommendations. Among the risks that promote dignity include the person's decision to work, to live in their own home, rather than in congregate care or a treatment setting. In my state of North Carolina, we are under a Department of Justice settlement because we have prevented people from moving out of group homes and adult care homes against their will under the guise of treatment. It's illegal. We can't do that. The Department of Justice came in. They did a review of our state. We see these settlements happening all over the country around this type of treatment requirement that limits a person's right to take a risk. We're also under dignity and respect looking at work. Treatment providers can fear employment due to fear of stress and relapse and loss of benefits. Research demonstrates the majority of people with behavioral health challenges want to work. We know that it's around 70-75%. Yet, we have an incredibly high rate of unemployment among people with mental health and substance use issues. It's nationally actually more around 82%, somewhere between 80 and 82. In my home state of North Carolina, it's 85.2%. Behavioral health agencies need to be well informed about employment as a path to recovery and a pathway out of poverty, and actually support people to move off of disability benefits, move away from subsidized housing, go to work, have the financial freedom, and be able to have the dignity and respect that goes along with that level of independence. So I am a person who is very much a stickler for this, and when I go into an organization, I try to find out what the belief systems are around employment, what the values are around employment, how we are discussing or not discussing employment with people, and how people themselves are viewing employment based on the information that they have. And then the last one is about labeling. Are we seeing people first and their diagnosis last? That is a hallmark of being recovery-oriented agency. I am really sensitive to language. So when I come to an agency and I'm hearing words like frequent flyers and non-compliant and manipulative and schizophrenic and service resistant and borderline, all those words that are unfortunately commonly used within our clinical system, I know that that agency has not truly embraced the respect that goes along with serving people with these diagnostic labels. Rather than using labels, respectful organizations try to understand what the person's needs, wants are, their perspectives and their challenges, and try to help them work to overcome them. So we want to eliminate the use of those words that are actually even more stigmatizing to people and are harmful to them. We know that there's a culture, and this is such an unfair thing that we do to our service providers. And I hate it for our new professionals coming into the field and our professionals who are getting burnt out, who have been in the field for a long time, is the expectations look something like this often, that you have to have authority and everything is under the guise of ethics and boundaries. You have to know what's best and make decisions for people. You have to be able to fix things, and safety and liability is number one. It's an unfair responsibility that we put on service providers to be able to do all of these things for people. And what it does is minimize the person's role in their own life in developing the skills to be able to live the life that they want away from a service provider. So we really need to look at this culture that we've created and identify ways that we can start to unravel it a little bit, because in the long run, it is just not helping people. It's this idea of giving up power and control and not having to have the answers for somebody else, but really sitting in a lot of discomfort by saying to them, you know, I don't know. I don't have the answer for you on this. What do you think you should do? Let's try to figure out what your options are. And what's our next step? Having that humility and not being in the role of being the expert is vital in a recovery-oriented organization. Supporting that dignity of risk, we don't have time to get into it. As a CEO of an organization that serves several hundred people that are either currently homeless, that are currently incarcerated, who have just come out of a legal system, come out of prison, that have just come out of hospitals, I know that what we do is risky. Every single day, the work that we do is risky. The easy thing for me to do as a CEO is to try to put standards in place that eliminate any perception of risk. And the truth of the matter is that the field that we are in is risky. So we need to make calculated risks, and we need to support people to make calculated risks, and then help people with that safety net. We don't want to prevent people from making decisions that could be risky, because that's how people learn how to live their life and have the best life. It's not an easy thing to do as an agency administrator. And of course, I talk to a lot of CEOs and do a lot of trainings for executive leadership on how to balance the risk with the recovery. Okay, we already talked about language, so I'm not going to belabor that, but you will see that there are examples here of language that we look at. The diminishing language by referring to somebody as a category, like a cutter or a frequent flyer, catastrophizing language, afflicted by, plagued by, suffers with, they suffer with voices, they're afflicted by mental illness, is catastrophizing language, patronizing, calling people my girls or my people, demoralizing, people like that don't get better, the low functioning versus the high functioning, and categorizing people as schizophrenics, bipolars, manic depressants, Medicaid, the mentally ill. Those are the types of language. I love this quote. It's absolutely one of my favorite quotes. To call someone lazy, unmotivated, or non-compliant is to admit that we don't understand them. So using those labels say more about us than it does about the person. And what it says about us is we don't know how to effectively help them. And so it's easier to say that they are the problem than to actually really try to understand what it is that they're going through. Okay, so let me get through these really quick. So we have a couple of, actually we're getting close to the end. So let me just to get through these couple of slides. Factor 3 is natural support networks, and that's about how we are connecting people to AA, NA support groups, social media, online relationships, intimate relationships, reconnection with children, friendships, and family members. It's part of what we are looking for. Factor 4 is protection from abuse, neglect, mistreatment, and exploitation, and we already talked about that. We're looking at forced treatment, coercive treatment, seclusion, restraint, and involuntary commitment. Lots of work is being done around trauma. I'm giving you several slides that show you how a hospital actually turned around to become a trauma-informed environment. Just because we know that over 90% of the folks coming to services have experienced trauma in their lives. And unintentionally, our service can often re-traumatize people and exacerbate their issues rather than help them heal. So this is one example from one hospital that really made that transformation. There are resources in here about becoming a trauma-informed agency and learning those skills. Factor 5 is best possible health, and that's decision-making, primary care, use of psychotropic medications. Again, I have a lot more information that we will ever be able to go over in an hour. Those of you who know me are laughing right now. Factor number 6 is about safety. That's not just about the equipment, but that's also about helping people develop their own personal safety skills around wellness planning and wellness self-management. So there's a lot of information in here about what wellness self-management is and how it enhances personal emotional safety. Okay, we're almost there, guys. Factor 7 is staff resources and supports. Is your agency employing people with lived experience? Do you hire peer support specialists and certified peer support specialists as a part of your organization? Recovery-oriented agencies incorporate people with lived experience into their agency. And there's a lot of information around that in here. Factor 8, positive services and support. And that is actually moving from being person-centered to person-directed, person-driven. Oh, and I love this slide. When somebody says their goal is to have appropriate behaviors, listen to staff more, be compliant, follow the rules of a group home, be treatment compliant, manage my outbursts, stop being sarcastic to staff, maintain psychiatric stability as evidenced by, take my medications and shower daily, I know that that is not a person-directed plan. So I can look at a plan and tell right away whether it's the person's plan or whether it's the organization's plan. And so we do look at that when we are doing our BA and our POM assessments. This is a resource for you of how to support people to get in the driver's seat of their own treatment and help them develop their own plan. And then Factor 9 is all about continuity and personal security. You're going to see more and more in behavioral health this focus on asset development and financial literacy. There is a beautiful curricula out there from Judith Cook, who is at the University of Chicago. You can literally pick it up and support people to develop their own financial literacy skills. And so that is something we're looking at under continuity and personal security. And then, of course, the Factor 10 basic assurances system. We're looking at the inclusion of diagnostic assessments such as GAF scores and locus, CalLocus, and ASAM criteria if your agency uses any of those. We are looking at proof of eligibility and medical necessity for the services that are being provided, and that the interventions are consistent with the person, what they want, with their plans, with their personal goals. We are also looking for transition plans. We're not just discharging people without any sort of step down or transition in place. We're looking for things like psychiatric advance directives and relapse prevention plans and good usable crisis plans. We're looking for the use of evidence-based practices that have fidelity, and we're looking for data on some basic information such as homelessness, incarceration, trauma history, substance use, suicide, all of those safety issues, which are oftentimes the reason why people come into services. So we're looking at all of those things to be integrated into your BA system. Whew, I did it, and I think it's just about time. So as a reminder, we have our conference coming up, our Gateway to Quality 2015 conference, October 20th and 21st in St. Louis, Missouri. I am going to stay on the line. I see that I'm like, I don't know, 3 minutes late. But I'm going to stay on the line because I really do want to be able to answer any questions that you may have. So, Seth, can you open those lines up?
Yes, I will. I'm unmuting the attendees so they can ask questions. You can also type them into the question box. We did have one question earlier that I can address, and that was regarding sending around the PowerPoint slides and the recording of the webinar. I will be sending out an email to all attendees of all of the webinar series webinars with a link to where they could download and watch the webinars.
Absolutely. You could also, as an agency, if there are any topics on here that you think, you know what, we really need to have this as an agency, please let us know, because I would be happy to arrange it and figure out how to come to your organization or do training specifically for your team.
So people
are there any other questions? Yep.
Any other questions from attendees? It doesn't look like there's any questions at this time, Cherene, but obviously they can follow up with us after the fact if they formulate any. And again, we will be sending along slides and the webinar recordings to all attendees. And mainly, I would just really like to thank Cherene for putting all these webinars together in a really fantastic webinar series, sharing all sorts of really valuable information, resources, and expertise. We've reached well over 100 different people with this webinar series, so we just really appreciate all your work that you put into this, Cherene. It's much appreciated.
Thank you so much, and thank you everybody for joining us for this series.
Great. Well, thank you all, and again, you'll be receiving an email shortly. Thank you.
Wonderful. Have a great week, everyone.